First of all, I would like to thank the organization for this invitation. I'm not going to go into again, the pathophysiology and the differences between women and men. I think Dr. Cadro made a very nice illustration of this. Of course, there are obvious differences in our hormones. Estrogens avoid the antioxidative effect and avoid the degeneration and the fibrosis of our tissues, and there are differences in the autonomic tone. We have a higher parasympathetic tone and lower sympathetic tone. And also the progesterone and our X chromosomes act in the atherogenesis with less production of LDL cholesterol and an anti-inflammatory effect. What are the differences in the prevalence of the tachycardias, of the different kind of tachycardias between genders? In green, you have the more prevalent tachycardias in women. By far, the winners are inappropriate sinus tachycardia and AVNRT in women, and less frequently POTS, and even more rarely idiopathic right ventricular tachycardias. And as you may know, we have longer QTs by nature. And when we have long QT syndrome, it comes with more ventricular arrhythmias. More prevalent in men, accessory pathways, atrial fibrillation, ventricular tachycardias because they have more ischemic heart disease, Brugada syndrome, AV blocks as they have earlier degeneration of tissues and the conduction system also, and carotid sinus syndrome. So I'm going to focus on the SVTs, the most prevalent SVTs in women, which are inappropriate sinus tachycardia, AVNRT, and POTS. And at the end, I will mention something about the atrial fibrillation differences. The definition of inappropriate sinus tachycardia is a persistent or paroxysmal but unexplained tachycardia, sinus tachycardia, with a resting heart rate of more than 100 beats per minute and associated with symptoms of distress. It is 4 times more prevalent in women than in men. I don't remember any men in the clinic complaining about sinus tachycardia. Normally, they are young females between the age of 15 and 45. And sometimes it goes underdiagnosed because the patients are labeled as anxious or depressed. What are the mechanisms? The mechanisms can happen at different levels of the chain. It can be an abnormality, a defect of the sinus node itself. It can be an imbalance of the autonomic system with higher activity of the sympathetic system and lower activity of the parasympathetic, or can be at the level of the neurohormones or the receptors of these neurohormones, at the level of the type calcium channel, the funny channel, or the beta receptor. The diagnosis of inappropriate sinus tachycardia is diagnosis of exclusion. The first thing you have to do is to exclude all these things that can cause sinus tachycardia. Of course, it can be physiological, dehydration, stress, fever, pain. Pregnant ladies have higher heart rates, as you know. Can be medications or substance abuse or other medical problems like anemia, many other problems. The symptoms, the main symptom and the most frequent are palpitations, of course, fatigue, shortness of breath, dizziness, intolerance to exercise, less frequently chest pain and headache. The symptoms must be correlated to the heart rate. This is very important. What I tell to this kind of patients, of course, I do always a Holter. And when I request the Holter, I tell the patient, please, the day you do the Holter, or the 2 days or 3 days of the Holter, you will take a piece of paper and you will write your symptoms, what kind of symptoms and at what time. And you have to correlate these symptoms with what happens in the Holter. So it's not enough to have an average rate of more than 100. You have to correlate these symptoms. These symptoms usually lead to physical debilitation, and this is a vicious cycle. The patient does less exercise and more tachycardia, and like this. It can be persistent or paroxysmal episodes, as I said, and it can happen after an ablation of AVNRT or atrial fibrillation. Why? Because when we burn an AVNRT in the septum, in the area of the slow pathway, or an atrial fibrillation in the left atrium, there are many ganglia around in the outside of the heart, parasympathetic ganglia, and this can be affected by the ablation. And sometimes after these kind of ablations, we have complaints of sinus tachycardia. Or it can be that the two problems coexist. And finally, it can be overlapped with other syndromes like vagal syncope and POTS. The diagnosis, as I said, it's an exclusion. It's a diagnosis of exclusion. First, exclude any secondary cause. Take the orthostatic vitals. So this is to rule out POTS. You will ask the patient, you will take the vitals in supine and then standing up for 10 minutes. And this is for the diagnosis of POTS, as I will explain later. Holter, this is very important, and to correlate the symptoms with what happens in the Holter. An echo, as in any cardiac disease, to rule out structural heart disease. Exercise test is optional, just to see the tolerance to exercise or to demonstrate an exaggerated chronotropic response to exercise. And sometimes, but very rarely, you will need an EP study if still is not clear if it can be an SVT. When it's paroxysmal and you have doubts, an EP study will tell you the answer. What is the treatment? The first of all is patient reassurance, to talk to the patient and tell the patient about the benignity of the syndrome. In most of the cases, they feel released, and together with lifestyle modifications, is enough for the treatment. You have to tell the patient to encourage to do some physical exercise. Seems that yoga could be the best kind of exercise because they do stretching, they do exercise, but they don't feel the tachycardization as in other kind of aerobic exercises. Avoid stimulants, avoid heat, of course, because it leads to vasodilation and more tachycardia. Leg compression and good hydration are very important. If this is not enough, the first choice for the treatment with tablets is ivabradine, because it's selective for the funny channels. It has been demonstrated to be superior to beta blockers and doesn't give the side effects of the beta blockers with hypotension, and improves the tolerance to exercise too. Sometimes you will have to add to ivabradine beta blockers if it's not enough, if the patient is still symptomatic and the Holter shows high heart rates. Normally, I don't stop ivabradine. If it doesn't work, I don't stop ivabradine to put a beta blocker. I just add beta blocker. And you have also calcium channel blockers or anxiolytics if it's indicated. What about ablation? This is the third step if nothing works, and still you have a patient very symptomatic. What is the problem of the ablation? The sinus node is a very diffuse structure. It's not like the AV node that it's 1-2 points and boom. It's a very diffuse structure, and it's difficult to burn the whole sinus node. Although this is not the point. This is not what we want. We don't want to block a complete block of the sinus node. We want a modification of the sinus node. So there is no clear endpoint for the ablation, when to stop, when to proceed with more ablations. And the sinus node is close to the phrenic nerve. You can damage the phrenic nerve, and usually one ablation is not enough. The rate of recurrences is very high, and normally the patients need more than one ablation. And as I am an electrophysiologist, I wanted to show you a case of ablation of inappropriate sinus tachycardia done in Rashid some months ago. This is the baseline heart rate of the patient. The baseline rate was 123 beats per minute. And this is the first map. This is the superior vena cava, and this is the junction with the atrium. This is the right atrium and inferior vena cava. And here in the red area, you have the origin of the beat. This is an activation map. This is the origin of the sinus beat. So it's the sinus node. I start my applications. The applications are the red balls. And after several applications in this area, nothing impressive happens. The patient is still around 120 beats per minute. So more applications are needed. I do a remap because frequently when you burn the sinus node, the origin of the beat shifts to another side. So you need remap and remap and remap. This is the second map, and after more applications here in this area, I get a heart rate of 94. Well, it's a change from 120 to 94. It's changing, but I was not happy with the result, so I decided to burn more. As I said, there is no end point. Well, yes, if you have 75, then better to stop the applications because it is a good result. But 94, I wasn't happy, so I decided to burn more. And with the following applications, this is what happened. There is a pause here. I stopped the application here. This is to demonstrate you that it's quite unpredictable what is going to happen in the next burn. This is the problem with this kind of ablation. So I stopped immediately, there's a pause, and there the patient ends with a junctional beat, and she continued having junctional rhythm. Stable, asymptomatic, but junctional rhythm around 50 beats per minute. So we stopped the procedure. In this case, you don't have to rush for a pacemaker, you have to wait because the sinus node has a big capacity of making reconnections. So we waited, and this is the Holter 2 months later, 2 months after the procedure. This is before, mean rate of 94, maximum 140, and there is a significant change with no junctional rhythm anymore. The sinus node recovered, made the reconnections, and the heart rate has improved significantly with a mean heart rate of 74. And the last step, hybrid ablation, I'm not going to extend this much because I have 5 minutes. Yeah. Okay, POTS. POTS is a very rare syndrome that almost never comes alone. it always in the context of something else. These are the conditions that can mimic POTS or can be linked to POTS. Basically, autoimmune diseases, gastric diseases, or mental, psychological diseases, and migraine, many, a myriad of conditions. The hypotheses of the causal hypotheses for POTS are not very clear. POTS has been considered a post-viral, can be post-viral infection, like in the post-COVID syndrome, can be because of peripheral denervation, alpha receptor hypersensitivity, all this list of potential causes, but nothing very, very clear. Diagnostic criteria, this is the most important thing I want to tell you. It's not orthostatic tachycardia and that's it. It has to be orthostatic tachycardia with an increase of 30 beats per minute in orthostatism, standing up, more than 40 beats per minute if in young people, and there must be no drop in the blood pressure. Otherwise, it's orthostatic hypotension with secondary tachycardia. No drop of blood pressure must be there. Another very important criteria is that it must be a chronic condition. It's not a thing that comes 2 days and then goes away. This is not POTS. The chronicity of the symptoms are important. No other explainable cause for the tachycardia must be there. Symptoms of orthostatic intolerance include postural chest pain, exertional dyspnea, other symptoms related to orthostatism. And a syncope is not a criterion, and the tilt table test is not necessary for the diagnosis. Just this test I told you, standing up for 5-10 minutes and comparing the vitals in supine and standing up. And this is a flow chart that I think is an interesting, good one to reach the diagnosis of POTS. First of all, first step, symptoms of orthostatic intolerance and improvement of the symptoms in supine. Yes, okay, it can be POTS. Second step, the symptoms were chronic, minimum of 3 months of the presence of the symptoms. Yes. And then you will do this test. If there is an increase of 30 beats per minute in orthostatic position, in standing up position with no difference in blood pressure, it can be POTS, but still you have, even if you have this test positive, you have to rule out any other conditions. And this is very important. It doesn't come alone. You have to probably refer this patient to internal medicine because you have to rule out lupus, you have to rule out many other conditions that have a specific treatment or may have a specific treatment and have maybe a worse prognosis than POTS alone. And the treatment, if you have POTS single with no any other disease, the treatment is exercise, hydration, like in inappropriate sinus tachycardia, very similar. Because for POTS, there is no treatment, there is no tablet that has demonstrated any benefit. Many drugs have been published. All these lists, fludrocortisone, midodrine, modafinil, a myriad of things, but there is no evidence of any benefit, and maybe propranolol is the one that has more publications compared to placebo. But of course, beta blockers have side effects. So in my opinion, ivabradine should be or midodrine or fludrocortisone should be the drugs, or the drugs I use the more. No time, what to do? Okay, 20 seconds? What do you give me? 2 minutes? Okay, deal. All right. So conclusion for POTS, it's a rare disease that usually doesn't go alone. Further investigations are mandatory to exclude other disorders. Diagnostic of POTS is after exclusion of other syndromes. There's a clear gap in evidence in the treatment of POTS, and apart from lifestyle modifications, no medical therapy has proved to be effective. And well, AV and RT, I'm gonna pass, because I want to tell you some differences in atrial fibrillation. It's more prevalent in men, but there are significant differences in the prognosis of the atrial fibrillation regarding stroke. For example, in the last European guidelines for atrial fibrillation, maybe you don't know, the CHADS-VASc, the SC has disappeared, the sex category, and now it's CHADS-VA. Why? Because the female gender is not, we cannot consider as an independent risk factor for stroke. Young women have not, that don't have a bigger risk of stroke compared to men, and is an age-dependent stroke risk modifier. This means that, especially at over the age of 75, women have an increased risk of stroke compared to men. But it's linked to the age, it's not an independent risk factor per se. And of course, the anticoagulation of choice is the same, the DOAC. Well, I think I have no time. All right. Thank you so much. Sorry for this. It was very long.